Welcome, and thank you for tuning in to On the Go with CAO, a podcast by the Centers for Advanced Orthopaedics. Join us as our orthopedic specialists share their tips and advice for keeping you on the go and in the know, including the latest on how we're treating and caring for injuries and diseases of the body's bones, muscles, joints, ligaments, and tendons. We're here with over 60 offices in Virginia, Maryland, and DC to keep you active and on the go.
Hi, welcome to our podcast. I'm Dr. Barry Waldman, a joint replacement specialist here at the Centers for Advanced Orthopaedics, and this is the first of our series on joint replacement. It's going to be in two parts. So we're talking about joint replacement today, and that basically involves replacing worn out joints like the hip, knee, and shoulder. And of course, many patients have extremely worn out joints that need joint replacement. But one of the first things my patients ask me is, what are the things we can do that isn't surgery? So Dr. Gupta, why don't you tell us some of the treatments that we pursue that are not surgical in nature?
Absolutely. So I always tell my patients that surgery should often be the last resort. So in terms of non-operative measures, there's lots of them. So one of them is you talk to patients about trying injections, or therapy, or bracing, or anti-inflammatories, all of which can help. In terms of injections, there's gel injections and cortisone injections. With insurance companies these days, you have to try the cortisone injection first. And the way I explain that to patients is that the difference between the two is that a cortisone injection is more like, it's a steroid, it decreases inflammation, it's the decrease in inflammation that makes the knee feel better. Whereas a gel injection, I liken to a motor oil. You sort of inject it into the knee, it coats the joint surfaces, and that's what makes it feel more comfortable. But really, at the end of the day, I present all these options to the patients, but every patient's different in terms of what's acceptable to them. Like some patients, come in and because of their normal daily clothing wear, like, doc, I'm not really going to wear a brace. That's reasonable. I understand. Like wearing a brace can be cumbersome and it's hard, and just because of social dynamics, they don't want other people to see them wearing a brace. So I said, it's fine. And other people come in, they're like, I absolutely am deathly afraid of needles. There's no way you're going to get near me with a needle. I'm like, oh, that's fine too. Like, again, that's why there are options. And there's no right or wrong answer. It's not like we must follow this protocol before, it's really what's acceptable to the patient.
Yeah, one of the modalities we like to emphasize is exercise, weight loss. These are different kinds of things that can help the patient out without using medications, without using injections. And we found that a lot of patients, while you can't get rid of arthritis through exercise, you certainly can mitigate the symptoms by reducing the amount of force that goes to the joint. We often use physical therapy to strengthen the muscles around a joint, give it a little extra support. So there are a lot of things we can do that isn't surgery. We never want our patients to feel that just because we're surgeons that the first thing we're going to do is operate. As a matter of fact, statistically, we operate on 1 out of 20 of our patients. So quite a few of them we treat without surgery. But sometimes our patients do get to the point where these methods don't work. The injections are not helping them. Exercise isn't helping them. We aren't able to control their pain with medications. So Dr. Anvari, when the patient gets to that point, what kinds of indications do you see? What makes you say to the patient, hey, you are a candidate for surgery?
But at the most basic level, it is someone with severe arthritis who is either having significant pain or dysfunction, and it's significantly affecting their life, and they've already tried all the reasonable non-surgical treatments. There are some nuances when it comes to patient age, patient BMI, medical risk factors, but the bottom line is someone who's suffering severely from arthritis and has failed non-surgical treatments.
Do you think they have to wait until they are, say, completely miserable?
Not necessarily. I think you factor in the life circumstances. I generally tell people that I categorize them from an age range into 3 age categories. 65 to 75 being sort of the ideal 10 years to have a joint replacement where they're old enough to probably not need a revision surgery in the future, but also young enough to have the fitness, stamina, and wherewithal to get through the rehabilitative process. So I factor age into it. But no, I don't think they need to be necessarily completely miserable. I mean, your life goals matter. If your goal is just to, walk a bit and see the grandkids and not be very active, there's certain indications, or perhaps more emphasis on non-surgical modalities and can wait longer. And whereas with those who have more active demands, sometimes it's a bit sooner to surgery.
Are there some medical conditions that would make you pause or maybe not do the surgery?
Certainly. I mean, we rely heavily on the medical doctors who know the patient best and probably have a longitudinal relationship with them for years as to ultimately deciding if they're not fit for surgery. So we asked all the primary doctors for a medical clearance. But there are other mitigating medical conditions which can factor into the decision for whether it's wise to proceed with surgery or whether they should be optimized. Things like smoking cessation, reduction of BMI to more lower risk levels, optimization of other medical conditions like diabetes, hepatitis C now, which is curable, and others. But that's where you need to have a very sort of personalized conversation with your surgeon and your medical doctor.
Yeah, it's certainly going to be challenging, and there's research that is getting more and more mature with time, showing that if somebody has a very high weight, a very high body mass index, that the surgery can become too dangerous to do. You can actually have too high a complication rate. So a BMI or body mass index, it's kind of a ratio of your height to your weight, and it comes out as a number. And when the number goes much above 40, we find the complication rate goes up dramatically. Now, it doesn't mean we can't do it in patients whose BMIs are, say, 42, 45, 46, but we have to be a lot more careful about complications. We have to really consider their medical condition much more carefully. But so Dr. Gupta, another point that comes up a lot is what if you have a younger patient? What if you have a patient who's 52 years old? They have a very worn out joint. What considerations do you have at that point?
No, absolutely. And I just want to second what you're saying about the whole BMI thing, that when the BMI is getting pretty high, you start to worry a lot more about that sort of patient. But then again, that's where the medical weight loss, programs and such, there's a lot of them out there right now that can really help optimize patients. And, as long as the patient's on that track and they've tried those programs, then, at least we're trying to optimize them. If you're younger and you have no quality of life and things are really challenging for you, and then I think it's, I always try with those patients to try all the non-operative stuff first. And I say, look, you're young, let's try all this non-operative stuff first. But if it gets to the point where that stuff just isn't working, then maybe it's time to say, look, because having that patient wait until they're 65, it's like their quality of life that they want to enjoy is now. So if they wait until later, it's like, who knows what's going to happen at that time.
It's very, very challenging. And the way I often present it to my patients is, say you're 50 years old and you need a knee replacement. That knee replacement might wear out in 10 or 20 years. But when you're 50, when you're in your prime earning years, when you're busy, you have family, you can't slow down, do you want to trade those 10 or 20 years for your 70s being really good or your 80s being really good? Exactly. And most patients say, I got to take care of this now. I can't wait 20 years to have a joint replacement. And we're also finding that they're lasting much longer than they used to. So it's not necessarily that tight a trade-off, but it is something we think about very, very carefully. Another thing that, I think as we as surgeons, we sort of assume that people know, but I'm not sure that it is totally obvious. So Dr. Anvari, tell us, why would you get a joint replacement? What will it do for the patient?
Well, it depends what you're suffering from. If the arthritis is leading to, most of the time it's pain. So, night pain, difficulty sleeping, difficulty walking, difficulty weight bearing, it is designed to alleviate those symptoms. For some people, it's not so much the pain, it's dysfunction, it's stiffness, it's limping, it's not being able to put on your shoes and socks with hip arthritis, it's not being able to go up and down the stairs. Even if the pain is tolerable, sometimes it's the dysfunction but for most people, it's a combination of the two. So the goal of the surgery is primarily palliation of pain and also restoration of acceptable function.
Yes, yeah, pain and function is a great way to put it. And a lot of people, it isn't real obvious as to what it might do for them. A lot of my patients say to me, "Oh, am I going to have some horrible limp afterwards?" And my answer is no. We're getting rid of your limp, and the vast majority of patients are going to have better function, better pain control. And another thing that we talk about a lot, and again, it seems like real obvious to us, is what actually is a joint replacement. So some of my patients think we just kind of take your whole knee out, we take 6 inches of knee out, and that's not exactly the case. So Dr. Gupta, why don't you tell us what a knee replacement actually is?
Absolutely. So the way I talk to my patients about a knee replacement, I say a knee replacement is much like retreading a tire. You're just getting rid of the old worn out surface, and you're gluing on a new one. So you're preserving a lot of the native anatomy around the knee. You're preserving a lot of the muscles and most of the ligaments. There's a couple ligaments that sometimes are taken, but again, it's mostly just the surfaces that are being replaced with a knee replacement. So that's how I'd explain a knee replacement. With a hip replacement, it's obviously a little bit different. You can kind of think of the hip as a ball and socket joint. So when the hip goes bad, that head ball is essentially rendered somewhat useless. It's not really doing much for the patient. So with a hip replacement, you have to get rid of that head ball. But when you make that cut, you actually expose the marrow space. So the marrow space, I kind of explain as like when you look at a chicken bone, it's that inside spot in the chicken bone. So we're sticking a spike or a stem inside the chicken bone, inside that marrow space. And then on the cup side, we put a cup. We use a device that sort of fashions the bone into the proper size. We get the metal cup in there. So you have a metal cup and then the metal stem. And then the head ball is either ceramic or metal, and then there's typically a plastic liner. So but again, even with the hip replacement, you can do these surgeries. It's not take big chunk of body out and put in, it's, again, you're just taking out the surfaces that are worn out and replacing them with new ones.
Yeah, that's a great way to explain it, I think. And again, people think we take out a lot more than we do. A lot of the time, the amount of bone we're taking out is pretty small. It's just a couple of ounces. And as Dr. Gupta said, we're preserving a lot of the ligaments, the tendons, the muscles, so that the joint will function the way it used to after the surgery. And we're going to actually do a whole segment about the surgery itself and the different kind of parts that we use and the different kinds of approaches. But Dr. Anvari, you want to tell us a little bit about the materials that these joints are made out of?
Sure. I want to echo what Dr. Gupta and Dr. Waldman just said. And the concept sometimes that people have of what joint replacement involves is sort of a carryover from decades ago. People will come in and say, well, I've been putting off coming in for my hip or my knee because my grandfather or my father or my mother, they had a 2-foot scar and they had to go to a rehab facility for 2 months and they had a terrible recovery. And things have changed dramatically in terms of the surgical process, the surgical incision, the minimal invasive nature, and just fixing what we need to fix. But as far as the material specifically, there's a bit more variety in the hip arena where the standard hip replacements now involve titanium as the stem and the cup. Those are the parts that go against the bone. Titanium stem goes in the femur. Titanium cup goes in the pelvis. And then the materials, as Dr. Gupta said, the head ball can be typically ceramic. or metal. More and more ceramics are being used than metal is. And on the socket side, typically a liner, which in the old days we would consider plastic or metal, and these days it's typically plastic or ceramic. So you can have a ceramic on ceramic bearing, a ceramic on plastic bearing, or a metal on plastic bearing.
The patients, in our office, we've decided we're going to do a joint replacement, whether it's a hip or a knee or a shoulder. And of course, we have to start preparing the patient for the surgery. And this is actually an area that has developed tremendously over time. It isn't something where we just tell the patient to show up on a certain morning and not know what's happening. So Dr. Gupta, maybe you can tell us some of the things that people do before the surgery to prepare for it.
There's things that the patient does, like prehab. So it's exercise that you start before surgery, and some of it's really hard for the patient because their joint hurts, and so you're telling them to do these exercises and they're like, come on now, I can't do any of this. What are you like? But some of it's also to sort of put in their mind, these are the things that you're going to need to do after surgery, and these are the things that you're going to be able to do after surgery. So it's sort of like getting them ready, getting them, and whether or not they're actually able to do it before surgery or not, it's at least mentally preparing them. And then you have the social work and case management piece of things, just making sure your home is ready, making sure that your home has a safe environment. You got rid of all your throw rugs, you have like railings, and you have your bathroom safe. These are all things that you may or may not think about. You go into surgery thinking that I'm going to be $1 million afterwards, and I'm not going to need any of these things. But for those first few weeks, when you're recovering and your body's adjusting, a lot of those things are really helpful, just to keep yourself safe until all those things are rendered useless and you don't need them anymore.
Do you feel it's important to get patients' expectations in line? I find sometimes that patients kind of expect to get better, the day after the surgery, and the surgery has gotten much, much easier, and recovery has gotten much, much faster. But it's still surgery, and we always have to be careful kind of not to oversell how fast you get better. So how do you counsel your patients?
Some patients come in and, we're going to be talking about approaches later, but specifically talking about anterior approach, for the hip, patients come in thinking that they're going to get this hip replacement and walk out completely normal. Yes, recovery can be a little quicker, but it's not like you walk out from surgery normal. You have to. So tell patients that, look, within a couple weeks, maybe, the goal is to start transitioning off of walking aids. So at 2 weeks, maybe you're using a cane, sometimes nothing at all. And I say by 6 weeks, you should be doing reasonably well.
Yeah, that's a great point. And, a lot of our patients, we tell them, hey, a month, 6 weeks, you're going to feel pretty good. It might take you 3 months to feel, great. And sometimes we have to really advise people that, not only these averages, it's not like they can speed it up all that much. But once it does heal up, the results are pretty dramatic and pretty impressive. So it's our job to kind of counsel people. So Dr. Anvari, so the patient, they're doing physical therapy, they're walking up down the halls in the hospital, they're doing some stairs. Tell us about the first few weeks. They go home. What happens their first few weeks at home?
Sure. It's, of course, it's individual. Your 55-year-old fit person recovers a bit differently than your 80-year-old less fit person. But generally, it's just a gradual improvement process. The first few days tend to be where the most inflammation is, whether it's a hip or knee. There's a certain inflammatory arc that takes time to fully blossom and gradually diminish. During that early time frame, I tell people just maybe up to a week, you really emphasize icing. You don't want to be too sedentary, which helps circulation and reduce the risk of blood clots. And you do physical therapy, whether people choose to do that sort of self-directed at home after having undergone preoperative education, or if they do it with home physical therapy, or if they do it with formal outpatient physical therapy. It's sort of individualized. Depends on the circumstances. But with knees, for example, it is primarily early on an emphasis on, well, with everything, it's safety. So use a walker until you don't need it, and then a cane for a while until you don't need it. But with knees, emphasis on range of motion, and then strength and gait and getting rid of your limp and all that. And it does take a little while with knees. With hips, they do tend to recover a bit faster. I've noticed, particularly with some of the less invasive anterior techniques and whatnot. I actually tell people not to get ahead of themselves, like you said earlier. The patient that wants to do twice as much doesn't recover twice as fast. Sometimes they're actually pouring kerosene on a fire that's trying to burn out. And I caution them to be moderate and patient, and they recover as they heal.
Yeah, that's a great point. And, some of the functional milestones happen a lot sooner than your full recovery. So a lot of my patients find that by 4, 5, 6 weeks after the surgery, they're driving, they're on a cane for a while, they're kind of getting rid of their cane, they're getting more active, they're able to, say, ride an exercise bike or walk outside or even swim. But maybe they don't feel, fabulous, and it can take 2, 3, even 4 months to feel really, really good. We even find that the patients functionally get a little better between that time and a year after the surgery, and even a tiny bit better between year 1 and year 2. So it's a long, gradual process. But for a lot of patients, they want to know, hey, when can I drive? When can I go to a store? Can I go to a restaurant? When can I swim? When can I get on an exercise bike? And it's around that 4 or 5 week, 1 month kind of range. So the recovery is a gradual kind of process. And it's very important that we manage the patients through that and explain it as they go along. And a lot of these numbers we're giving are sort of averages. But Dr. Gupta, just tell us, like, say you're a year out from the surgery, you've had a knee replacement, you've had a hip replacement. What are you doing? What can you expect?
So just to echo what you were saying before about averages and that sort of thing and expectations for recovery and such, I just had a patient today who came into clinic who was 6 weeks out from surgery, and she's like, during those first 4 weeks, I regretted every moment of having done this surgery. And then she's like, now she's doing great. And she's like, now, thank you.
Isn't that nice?
I was like, I understand. It's, it can be hard during those first few weeks. And yeah, you might have some regrets and saying, like, why am I putting myself through this? This is silly. Like, I was better before but like.
So how do you tell them they're going to be, say, at 6 months or a year after the surgery?
Yeah, so
what will they be doing?
What I generally tell patients is that, you should be able to walk comfortably for good numbers of distances. Now, again, some of that is dependent on what their functional level was before surgery. So you have patients that come in and they've been in a wheelchair for X number of time. Some of it's dependent on what the patient's functional status was before, like how much, because some patients really don't have a lot of stamina. Like, they're older and they don't have like that reserve. They don't have the ability. So if I say, like, you're not going to make a person who has never walked a mile in their life all of a sudden walk a mile after the surgery, but so my goal is to get them feeling more comfortable, being able to do more things within what their reasonable capabilities are. So, it's so for your younger patient, getting them back, and I say biking, swimming, hiking, doing all the things, enjoying time with your family, getting on the ground and playing with your grandkids. All those things are reasonable expectations for after surgery. So those are the things that I tell, those patients that I can reasonably expect to do that sort of thing, that those are the things that you should reasonably be able to do. Get back, enjoy life, like not wake up every morning and take 30 minutes to an hour before your joint is comfortable enough to just move. Like, you can get up and enjoy your life and enjoy the activities that you've missed out on for a period of time.
Yeah, not all of our patients have dramatic recoveries, but a remarkable number of them do. And I've seen some really, really inspiring stories. I've had patients send me pictures of them at the top of a Mayan pyramid. I've had patients show me pictures of them climbing trees. I've had patients that are, duck hunting way in the woods someplace where they hiked. We have patients that do beautiful Tai Chi on multiple joint replacements. Dr. Anvari, I'm sure you've had some dramatic stories. What are some patients that you remember that really got back to something impressive?
Well, it's funny you mentioned the guy climbing the tree, because rather than being thrilled when I see that picture, I say, please climb slowly back off that tree. So yeah, I've got pictures downhill skiing, to your point, riding a Harley, riding a horse, kicking a soccer ball, none of which I am terribly thrilled about, but the patient is. I say that I'm not thrilled because I'm worried about them wearing it out too quickly or having an accident and a fall where they could injure themselves seriously. But yeah, it's absolutely wonderful. To your point, the level of satisfaction you get when a patient just genuinely, deeply thanks you for restoring their function and relieving their pain. There's nothing better. And I'm sure you feel the same way.
We're very lucky that we get to do what we do. It's really a wonderful specialty for us, and it is really wonderfully gratifying when our patients do it as well as they do. Well, I'd like to thank you both for being here. We're going to do another episode about the actual technical aspects of joint replacement. And I'd really like to thank Dr. Gupta from Frederick, Maryland, and Dr. Anvari from Anne Arundel County, Maryland, and myself from Northern Baltimore. And on behalf of CAO, thanks everybody for listening, and we'll see you in the next episode.
We hope you enjoyed this episode of On the Go with CAO and invite you to tune in next time. To learn more about our upcoming episodes or to check out our online library of previously broadcast episodes, please visit cfaortho.com/hub. That's /HUB. Or search for On the Go with CAO on your favorite podcast app. Want to help keep others healthy and on the go? Then please share this episode. At CAO, you'll find over 160 orthopedic specialists committed to providing patients with an exceptional standard of care. The information contained in the On the Go with CAO podcast is for informational purposes only. It is neither intended as rendering medical advice nor as a substitute for seeking professional medical assistance. No relationship between the Centers for Advanced Orthopaedics and its practitioners may be created through On the Go with CAO. Any individual with specific questions regarding his or her individual health or treatment options should contact the Centers for Advanced Orthopaedics and schedule an appointment with one of its practitioners.